Okay, so تحياتي للجميع again. Today we'll be talking about the basal ganglia. In the first part of the lecture, normal physiology, circuitry, cell types, other aspects of the circuit. And the second part is going to be about the disorders of the basal ganglia, in particular Parkinson's disease and Huntington's. We'll give our colleagues another minute or so to join us here, and then we'll get started. Before we go ahead, any questions? Let me see. أي استفسارات عن اللكتشر من المرة الماضية؟ تحياتي جيهان، كيف حالك؟ So Jihan left as well. All right, so everything is set. Any questions? All right, so we'll start in a minute so that we give everybody the chance to join, and we'll move forward based on that. Meanwhile, if anybody has any questions, please post it or unmute yourself, and I'll be happy to answer your question, guys. Okay, so let's get started, and we'll get to any questions as we move forward. All right, before we move forward, quick question, guys. Did you cover any material related to neurotransmitters, neuromodulators, dopamine, serotonin, acetylcholine في الفيزيولوجي 1 ولا هي أول مرة بتسمعوا في هذه المصطلحات؟ Okay, so Misk is telling us it's saying yes, so excellent. Thank you, Misk. And you, an anonymous attendee says you covered that in a previous system. Okay, great. So that makes my job a little bit easier. طيب ممتاز. إذا خلينا نحكي على motor systems in the brain. In the major context of motor control in the brain, you will hear a lot about the motor cortex. The motor cortex. And مين بده يحكي لي pre-central ولا post-central motor cortex? Central gyrus. Mira, what do you think? See if I can unmute you, yeah, Mira. Okay, go ahead. تفضلي.
Pre-central gyrus.
Precentral gyrus. Precentral gyrus is the motor cortex. And postcentral is what?
Somatosensory cortex.
It's actually the sensory cortex. Exactly. Somato is part of it only, but it's majorly the sensory cortex as well, and it has multiple gradations. So it's excellent. And then basically بناء على الموتور cortex aspect of things احنا بنعرف كيف signal is basically carried from the muscles to the brain or from the periphery to the brain and from the brain to the periphery. مظبوط؟ شو بنسميه السيستم هذا؟ what do we call it؟ من وين بمر الموتور output of the brain؟ what do we call the system? Where does it pass through? In the medulla oblongata. بناء عليه بنسميه what kind of system? The corticospinal tract.
Corticospinal tract.
Exactly, pyramidal system. We call it a pyramidal system. ليش بنسميه pyramidal system؟ لأنه it goes through the pyramids of the medulla, all right? Anatomically speaking. هون احنا بنحكي على شيء بنسميه extra pyramidal system. So we have the pyramidal motor system اللي هو motor cortex and related cortices that actually send the projections down the spinal cord through the pyramids of the medulla oblongata واللي انتم عارفينه corticospinal tract and so on and so forth. وفي شيء بنسميه extra pyramidal system. The extra pyramidal system, one of the systems that we're talking about here is the basal ganglia. Another system that we'll be talking about, maybe not tomorrow, the day after, is the cerebellum as well. هاي ما إلها دخل في pyramids in particular. They don't pass their, their projections, afferent projections, through the pyramids. راح تشوفوا لما when you start actually looking and examining patients in neurology راح تشوفوا شيء بيسموه pyramidal symptoms and extrapyramidal symptoms. All right? فلما نحكي extra pyramidal symptoms, you're talking about coordination مثلا cerebellar related symptoms, or you're talking about basal ganglia related symptoms زي مثل الترemor مثل slowness of movement. راح نشوف Parkinson's disease مثل bradykinesia, you see, slowness of movement, مثل instability. These are things that you should actually kind of think about. All right? So بناء على هذا الكلام احنا هنا بنحكي على extra pyramidal motor system, which is what we call the basal ganglia. And why do we call it basal? And why do we call it ganglia? بجوز تسألوا ليش why am I actually kind of directing you in these particular directions? Because I really care about you guys understanding the concepts. مرات, if you know why the name is termed like this, ممكن تفهموا ما تبقى من context. And actually it makes memorizing and remembering these details much easier. And we call them basal ganglia. لأنه they're basal. They're in the base of the brain. They're subcortical, okay? And basically we call them ganglia. ليش؟ لأنه these are neuron bodies or neural cell bodies outside the cortex. Subcortical again. Inside the white matter, basically. The tracts that descend from the cortex. Therefore, we call them ganglia, basal ganglia. All right? And we'll talk a little bit more about other subcortical systems. And that being said, we'll be talking about the different components of what we call the basal ganglia. طيب. The major input structure of the basal ganglia is referred to as the striatum. Let's look at the figure. So basically, as you can see here, what we're seeing in front of us is this is basically the striatum here, as you can see, the one colored in orange. طيب شو اللي بمر بين الcaudate nucleus والputamen? It's what we call the internal capsule.
Internal capsule.
Exactly. So, and we have we call it striatum because of the striations basically that happen in the body of the striatum, and that actually is partly caused by this, intermingling of these internal capsule white matter axons that pass through it. And then ultimately راح نشوف طبعا basically ليش مقسم بمثل هذه الطريقة functionally speaking, إنه في عندنا caudate or the head of the caudate, في عندنا putamen, and في عندنا شيء بنسميه ventral striatum اللي هو بنسميه nucleus accumbens. And we'll see exactly why it's categorized like this. طيب إذا عندنا الستريتم, the major input structure. Beneath the striatum زي ما انتم شايفين في عندي the pallidum. The pallidum مقسم قسمين, external and then internal. All right? External segment and then internal segment. We'll talk a little bit about the significance of each one of these. In another structure in the basal ganglia, a lot of people basically consider it a little bit foreign to the basal ganglia. It's not really kind of indigenous from what is it called, from an embryological perspective. لأنه it's a very different type of neurons. لأنه everything in the basal ganglia is GABAergic except for the subthalamic nucleus اللي راح نحكي عنها حاليا, which is glutamatergic. All right. So كل neurons basically, mostly, well, actually, يعني, I'm saying almost 95% are GABAergic except for the subthalamic nucleus. طبعا sometimes of subtypes of interneurons that we'll be talking about as well in the striatum that are cholinergic as well. All right. But mainly we're talking about a GABAergic circuit. إذا شو حكينا حاليا؟ حكينا striatum, pallidum, external pallidum or pallidus, or what people call globus pallidus, external internal segments, subthalamic nucleus. وفي عندنا كمان the substantia nigra. Some people categorize it outside of the basal ganglia. Some people consider it to be a group of cells that are actually a member of the basal ganglia. Let's consider it a member of the basal ganglia for simplicity. Okay. Then the input structure of the basal ganglia is the striatum. The output structures of the basal ganglia are the globus pallidus internal and the substantia nigra pars reticulata. Then substantia nigra عندها فيها قسمين. Why do we call it nigra? Nigra because it's black because of the dopaminergic cells that have the melatonin, basically, I'm sorry, the melanin, stain, basically there or pigment, I'm sorry, that actually can differentiate their color as nigra, nigro, as black in Latin. So that being said, and كمان مرة, input structure is the striatum. The output structures are the substantia nigra pars reticulata, not the pars compacta. The pars compacta is the dopaminergic cells. So the pars reticulata is the output, and the GPI, the globus pallidus internal. All right. So ليش مهم البيزل ganglia? How does it work? شو بدنا في كل هالستراكشرز هذه؟ ليش يعني why do we need all of these switches in order for this to work? ليش بدنا caudate nucleus and putamen? Why do we need dopamine in particular? Why do we need serotonin? طبعا راح نحكي كمان مرة عن شيء بنسميه رافين nucleus and the regulation of the basal ganglia using serotonergic input. Maybe not in detail, but just for you guys to know how this works. Locus coeruleus input as well to subsections of the basal ganglia, noradrenergic, norepinephrine input as well, and neuromodulation aspects of the basal ganglia. All right, so بناء على هذا الكلام, let's start actually by talking about, where does the input to the striatum come from mainly? Who knows? زي ما انتم شايفين in front of you guys, right here. Okay, so وجدان is telling us from the cortex. Exactly. بس من الcortex. في other areas that actually project to the striatum. Thalamus projects to the striatum. Do you know that? Which part of the thalamus? There are some projections to the striatum from the thalamus, but basically it's what we call the intralaminar structures of the of the thalamus. They're like the central nuclei in the thalamus. مش راح نحكي عنهم كثير اليوم لأنه راح نحكي عن ventral anterior ventrolateral in particular, medial dorsal, maybe tomorrow as well when we talk about emotion. عفوا يوم الخميس when we talk about emotion, and then basically based on that we'll discuss that. But yes, there are some projections from the thalamus, but mainly from the cortex. Okay. And mainly we're talking about a glutamatergic input. So let's take a look at, again, at the striatum, the way that actually the cellular architecture of the striatum. Mainly we're talking about almost 90% of the cells in the striatum are called medium spiny neurons. Medium spiny neurons. These are GABAergic cells that actually receive all of this cortical input and then project to other parts of the basal ganglia, in particular either to the output structures in what we will call the direct pathway in a minute, or the pallidum, the external pallidum, the globus pallidus external in what we call the indirect pathway. طبعا في other projections من the striatum basically to the dopaminergic nuclei and to other aspects of the brain as well. طيب, before we move forward, and actually I start discussing the striatum, مين بيعرف how many dopaminergic nuclei we have in the brain? Or where is dopamine in the brain? Okay, أنا بديش عدد بس. If the person who said 3, you can. Another person says VT and SN, pars compacta. Okay, Mira is raising her hand. Let me ask Mira to speak as well. So Mira, you want to answer? Go ahead.
ممكن يطلع من السبستانشيا نيجرا، وممكن يطلع من كمان اللي هي تيجمنتم، الفنترال تيجمنتم، ومن الهايبوثالاموس كمان، من اللي هي اسمها الاركيويت نيوكلياي.
الاركيوت nucleus. So it's very important for regulating what? الدوبامين في الاركيوت nucleus.
التونيك انهبيشن للبرودكشن للبرولاكتين.
Prolactin. Excellence. Exactly. So basically, I want you to think about these things. The dopamine is not just in one place, but في some aspects of the subventricular slither of cells actually that produces dopamine as well. But basically احنا هنا major products that we're talking about here in terms of dopamine in the basal gang in the context of the basal ganglia are the substantia nigra pars compacta. ركزوا معي لأن البارس مثل ما اتفقنا البارس reticulata is an output structure. Pars compacta is the dopamine projection, and substantia nigra pars compacta mainly projects locally to the basal ganglia. Okay, the ventral tegmental area projects externally. عشان هيك راح نسمع شيء اسمه nigrostriatal pathway. Substantia nigra to the striatum. بينما ventral tegmental area راح نسمع about multiple other pathways related to dopamine, you see, that actually that are related to projection to the striatum. Which part of the striatum here we're talking about? We'll be talking about the ventral striatum, okay? And it's what we call mesocortical, mesostriatal, and mesolimbic pathways of dopamine, okay? So the ventral tegmental area mostly projects externally as well as to the striatum. Substantia nigra pars compacta mainly projects to the striatum, and of course other parts of the basal ganglia locally, all right? And actually it's not anybody who thinks that it's basically a very simple structure, you will not you'll be surprised how much complexity there is. يعني هنا في هذه lecture we're trying to simplify the architecture of the basal ganglia, the cytoarchitecture, the neural circuitry. ولكن حقيقة it's much more complex than what you will see, and we'll discuss this once we get to that. All right. إذن في الstriatum major كما اتفقنا major input structure of the basal ganglia. It's actually the largest in terms of size. We have these medium spiny neurons and also we have interneurons. Multiple types of interneurons, the most prominent of which is cholinergic interneurons. في كمان عندنا GABAergic interneurons, and I think recently there were some a subtype of them that have been identified that actually also produce dopamine, all right, okay, or respond to dopamine. So these are things that you need to be aware of. Mainly cholinergic interneurons is the major type of interneurons in the striatum. Okay, إذا عندنا medium spiny neurons راح نشوف ليش مهمين حاليا. Basically why do we care a lot about these medium spiny neurons. طيب ممتاز. إذا بناء على هذا الكلام زي ما انتم شايفين عندي cell body, and this is basically a dendrite, and basically these are the boutons, the dendritic regularities that actually other neurons come and synapse onto. So إذا ما انتم شايفين هنا when we get the extrinsic input to the striatum, what we call the dendritic spines اللي هم بيستقبلوا input من أماكن ثانية من الدماغ. Basically on the head of the spine we get the input from the cortex. All right. On the neck of the spine, we get the input from dopaminergic cells, in particular substantia nigra pars compacta. And for the thalamus, it both actually affects the head of the spine as well as the shaft of the dendritic cell. Okay? So these are things that you should be aware of. A question about cholinergic. Yes, cholinergic means it produces acetylcholine, this one, what we call the large interneurons. Okay? So cholinergic means it produces acetylcholine. Okay? So based on that, so كمان مرة نرجع للنقطة اللي كنا نحكيها على dendrites of the basal ganglia of the medium spiny neurons. So they receive inputs that are extrinsic, بيجوا من الcortex mainly على the head of the spine, بيجوا من dopaminergic cells in the substantia nigra pars compacta on the neck of the spine, and بيجوا من الthalamus on the head of the spine, as well as regulatory على on the trunks or the shafts of the dendrites. Okay? إذا بناء على هذا الاركتكتشر اللي شايفينه قدامكم, what do you think المين input اللي بيجي من وين؟ The main factor, the main player that we're talking about comes from where on these cells? Should be from the cortex. Then this is the most sensitive area of the dendritic spines is the head of the spine. When you have something on the neck of the spine, it's modulatory or regulatory. هذا اللي بتشوفه في الدوبامين. And if it's on the trunk of the spine, then actually trunk of the dendrite, it's even less regulatory, and that's exactly what you see in the thalamus. So it's interacting with the one from the cortex and doing a little bit more regulatory work on the dendrite of the medium spiny neuron. Okay? Then when I say input to the medium spiny neurons, بشكل عام, that means from the cortex. Dopamine input on the medium spiny neurons, this means the regulatory aspect of things on the neck of the spine. Okay? The interneurons, they actually act on the area where the dendrites report back to the cell body, and again they act they form significant regulatory roles as well, either on the cell body or around the cell body when the dendrites arrive at the cell body. Okay, and also they connect to each other as well, and they form these kind of really very versatile networks within the striatum, and so on. All right. إذا اتفقنا بس للتأكيد كمان مرة, الكورتكس والثالاموس are glutamatergic inputs on the medium spiny neurons of the striatum. Okay, so that actually leads to a particular concept that we should also be aware of when we talk about the basal ganglia, which is what we call the corticostriatal loops or corticostriatal circuits in this kind of context. لأن مثل ما اتفقنا, the striatum is the input structure of the basal ganglia. إذا في عندي a lot of inputs from a lot of different places in the brain that actually come and synapse on these medium spiny neurons in the striatum. طيب من وين بيجوا؟ من ناحية functionality. Let's just take a look. So as you can see here, we have 4 corticostriatal loops, or what people call cortico-basal ganglia thalamocortical circuits. ليش احنا بنسميهم cortico-basal ganglia thalamocortical؟ لأنه ببلش من الكورتكس, بيوصل للباسal ganglia, it goes through the basal ganglia, and then back to the thalamus, and then back to the cortex. Or for short, like if you want to use a short name for them, we call them corticostriatal loops. All right? According to their function, we have different categorizations بناء على originating cortex and the pathway in the thalamus. We have a motor, the motor loop, and actually it goes from the motor cortex to the putamen, this part of the striatum that we call the putamen, and then الoutput تبعها again of the basal ganglia, as we agreed, substantia nigra pars reticulata, not pars compacta. Pars compacta is a dopamine one, and the motor territory of that in particular, as you can see, actually this kind of green colored area, and then goes to the VL and the VA nuclei in the thalamus, and then back to the motor cortex. Okay, it initiates in a cortical area, goes through the a particular part of the striatum, then a particular part of the output structures of the striatum. So a particular part of the input striatum, and then particular part of the outputs of the basal ganglia, and then back to the thalamus, or to the thalamus, and then back to the cortex. This is what we call the motor. The oculomotor function comes from the eye fields, supplementary eye field or frontal eye field, as you can see here, basically in this kind of blue colored or I don't know, maybe you're better at colors than me, actually, guys. Violet colored cortical areas. It goes to parts of the rim of the caudate nucleus, and then, as you can see, in the substantia nigra pars reticulata, very particular central area of it, and then goes to MD and VL and VA in the thalamus, and then back to the same cortex and other areas, of course. We have the executive associative corticostriatal loop, which goes from the dorsolateral prefrontal cortex and the orbitofrontal cortex to the caudate, particularly the head of the caudate nucleus, and then through the SNR GPI, and then back to the thalamus, VA, VL, MD as well, and then back to the cortex. And then the last but not least is the emotion, motivation one. And it's actually really related to the cingulate cortex in particular, and orbitofrontal cortex as well, in particular the anterior cingulate cortex. The posterior is related to other stuff we'll talk about as well in one of the lectures. And actually the input goes to the ventral striatum, what we call this, I'm blanking on the name again. الصيام مثل علي بشكل كبير. So basically, nucleus accumbens. Okay, so basically the nucleus accumbens is the ventral striatum, and then ultimately based on this kind of cortex, it goes to the ventral striatum, and then the output structures of the basal ganglia, and then to the thalamus, and then again back to the same cortex. Okay, so that being said, مثل ما اتفقنا عندنا 4 different corticostriatal loops categorized according to the initiating cortex and the pathway in the basal within the basal ganglia and their function. راح نحكي اليوم mainly عن الموتور, a little bit of the oculomotor if we have time, and بكرة راح نحكي عن executive associative and a little bit about the emotional or the emotional motivation, and then the next lecture about emotion, which is on Thursday, I think. It's going to be about the emotion aspect of things, which is what we call the limbic pathway. And then we'll explore this in more detail, how this happens. Any questions so far? أي أسئلة؟ أي استفسارات? Any concerns? Any comments? Okay. إذن بناء على هذا الكلام, we covered the striatum as a cytoarchitecture. We covered the inputs to the striatum with all of these different loops. And now we will cover what happens after the signal leaves the striatum. Even after the signal leaves the striatum, let me see here. This is actually movement-related activity, as you can see here, in terms of the cortical areas, the subcortical areas, as you can see, the putamen here, and then ultimately how it's categorized into ipsi and bilateral. We'll talk about this later. All right. And based on this, once these neurons leave the striatum, they go in one of 2 pathways. They go into what we call the direct pathway. من الاسم direct pathway يعني من الانبوت للoutput immediately. من الstriatum للsubstantia nigra pars reticulata and basically globus pallidus internal, as you can see. All right. And then زي ما انتم شايفين هنا it differentiates a little bit. So you can see actually the head of the caudate or the caudate nucleus sends to the reticulata mainly, and basically as well as to the internal GPI, but basically from the putamen mainly to the internal GPI, okay, the internal globus pallidus. it's يعني when you look at the brain, actually there are no like very clear rules. Actually, if you look under the microscope, it's very rare that you see a neuron that looks like this. It's very, very rare. And there is always something that is not typical about the neuron. And we just do these figures in order just to simplify things and get to the point where we establish understanding. But the reality is it's much more complex than what you would imagine. And then based on that, as you can see here, we have these medium spiny neurons that synapse from the direct pathway to or on to the output nuclei of the basal ganglia, and we call this the direct pathway. And من الستريتم للoutput nuclei is called the direct pathway. All right? طيب, what's the other pathway? Is what we call the indirect pathway. إذن the indirect pathway is when these neurons synapse, they go out from the basically the striatum, as you can see here, to the globus pallidus external segment of the pallidum. And then from there, the neurons actually go onto the subthalamic nucleus. From the external pallidum, go to the subthalamic nucleus. And from the subthalamic nucleus, it goes onto the output nuclei of the basal ganglia, namely the reticulata and the internal segment of the globus pallidus. We'll talk about this in much more detail. You will see what we mean here in this kind of context. And let me just open a figure to make it simpler. So let me see. Oops. Let me just open it with the major reader so that you guys can see. Okay. So this is a simple box and arrow diagram of the basal ganglia, direct and indirect pathways. And as you can see here, from the striatum to the output is what we call the direct. From the striatum into the GPE, external globus pallidum or globus pallidus, to the subthalamic nucleus, and to the GPI or the output nuclei of the basal ganglia is what we call the indirect pathway. طيب, حكينا عن الاناتومي, and then from there, of course, to the thalamus and back to the cortex, which is what we discussed as well. Based on these different corticostriatal loops. طبعا اتفقنا انه كل واحد من اللoops هذه will actually utilize a particular anatomical preference when it comes to these output nuclei of the basal ganglia. سواء كان direct ولا indirect pathways. طيب, how does it work? Then when I say that there is a glutamatergic input that is coming from the cerebral cortex into the striatum or onto striatal medium spiny neurons, شو بصير في هاي النيورونز؟ لما احط glutamate عليها, what happens؟
راح يصير لها excitation يعني.
راح يصير لها excitation. طيب لما
وهي
انا
كابنرجيك هي كابنرجيك.
بس لا, هي مش dopaminergic, يعني medium spiny neurons are not dopaminergic.
لا كابنرجيك حكيت بتطلع جابا.
GABAergic. Okay, so it's GABAergic. Okay, so بناء على هذا كلام أميرة, once we release these release glutamate سواء كان من الcortex or co-release من الthalamus, what we will get there is an excitation of a GABAergic neuron. لما صار عندي excitation of a GABAergic neuron, شو بعمل? What does it release? This is GABA. Okay, وين الجابا بروح هذا؟ So as you can see here,
الانترنال سيجمنت للجلوباس باليدس
في الدايركت pathway. So بناء على الدايركت pathway, إذا كانت هاي neurons projecting to the direct pathway, yes, it actually will directly send GABA or GABAergic input to the globus pallidus internal as well as the substantia nigra pars reticulata. طب شو بصير في هدول structures إذا حطينا عليهم GABA؟ They'll be what? Inhibited. إذا أنا I am suppressing the activity of what? Of the output structures of the basal ganglia. إذن output of the basal ganglia, if I activate the direct pathway, will be diminished. طب شوفوا شو بصير إذا هذا الكلام صار. So what happens if I inhibit the output structures of the basal ganglia based on that? طبعا احنا اتفقنا إن كل major structures of the basal ganglia are GABAergic except for the subthalamic nucleus اللي هي glutamatergic. Alright? طبعا مع الاكسبشنز اللي كنا نحكي عنهم من ناحيه الانترنيورونز في الستريتم which are cholinergic and other types. ولكن اذا انا عملت suppression للاوتبوت of the basal ganglia by activating the striatum from the cortex, اذا شو بصير عندي؟ بصير عندي release للGABAergic inhibition of the thalamus. اوكي، لانه انا I suppressed this GABAergic pathway اللي هو من ال output structures of the basal ganglia to the thalamus. اذا هالسبريشن اللي كان على الثالاموس الانهبيتوري اسبكت اللي كان على الثالاموس خف. بناء عليه thalamic neurons are actually ايش بنسميه they're tonically firing، يعني دائما their activity مثل ما حكينا تتذكروا في السليب اول امبارح basically they're just releasing action potentials in the awake state in particular. So اذا بخف الانهبيشن عليهم بتزيد الاكتيفيتي تبعتهم alright over the thalamus. اذا زادت الاكتيفيتي تبعت الثالاموس احنا بنعرف انه كل النيورونز في الثالاموس except for the rim of the thalamus um, basically is completely glutamatergic. اذا بصير عندي glutamatergic activity اللي بترجع للكورتكس. شو بصير في الكورتكس؟ excitation. اوكي، بناء عليه اذا if the cortex is exciting the medium spiny neurons in the direct pathway, the ultimate outcome is excitation of the cortex back. اوكي، طيب خلينا نشوف شو بصير في ال indirect pathway. كمان مرة الكورتكس is releasing glutamate. alright, and خلينا بس نحط الدوبامين شوي على جنب حاليا. alright, we'll talk about it in a second. And then basically طبعا dopamine is extremely important in the process, don't misunderstand, but I'm just saying let's see what happens if the cortex only is functional in this kind of case. يعني بناء عليه انا لما يصير عندي excitation ل medium spiny neurons okay by glutamate, then what will happen here? What will happen is basically an increase in the GABAergic input of these medium spiny neurons. This means suppression of the globus pallidus external, and this means more excitation. Again, it's tonically active, is subthalamic nucleus, and therefore more excitation of the output nuclei of the basal ganglia. وهذا كلام شو بيعمل؟ بيعمل suppression للثالاموس. إذا زي ما انتم شايفين الكورتيكال input لحاله maintains the balance. كمان مرة indirect pathway, it's extremely important that you understand these concepts يا جماعة, and I want you to really be very careful when you think about these things لأنه يعني that's what I want you to get out of this lecture. If you understand these figures, if you understand the architecture of how the basal ganglia works, أنا بالنسبة لي وصلت رسالتي. يعني بالنسبة لموضوع البيزل جانجليا هون مش الموضوع مش إن نحفظ كل التفاصيل هذه، الموضوع إنه نفهم شو اللي بصير okay in this kind of structure so that you can generalize, you can understand the pathologies زي ما راح نشوف الباركنسونز والهانتنجتونز, and you can understand the pharmacology related aspects of Parkinson's and actually how treatment works and so on. In general how neural circuits work in this kind of regard. إذا كمان مرة indirect pathway لما يكون عندي أنا input من الكورتكس على medium spiny neurons in the basal ganglia in the striatum in particular بيعملوا لي excitation of what? Of these medium spiny neurons اللي هم GABAergic neurons. They suppress the globus pallidus external. عشان هيك السبثالاميك نيكلس بتخسر الGABAergic inhibition عليها. So inhibition, loss of inhibition or disinhibition, هذا كلام بيزيد الاكتيفيتي أو بخفف الانهبيشن, which are not the same thing by the way, and therefore this increases glutamatergic. اتفقنا إنه subthalamic nucleus is glutamatergic. Output of the subthalamic nucleus على ال output nuclei of the basal ganglia, substantia nigra pars reticulata and GPI globus pallidus internal, بزيد ال GABAergic output of these structures على الثالاموس, بينزل الاكتيفيتي تبعت الثالاموس. إذا كمان مرة الكورتكس excitation of the direct pathway leads to excitation of the cortex. Cortex excitation of the indirect pathway leads to inhibition of the cortex. إذا صار عندي balance, لا واحد بيحرك يمين ولا شمال. Why is dopamine important? لأنه here actually comes the segmentation that we will be talking about. بما انكم اخذتوا شوي من الcellular neuroscience aspect of things, how many types there are of dopamine receptors? مين بده يحكي لي؟ So اللي حكى لي D1 and D2 يعني 2 ولا 5؟ اللي حكى لي 5 how many families are there? Maybe I'm looking for a full answer here. About 5 شو يعني 4 ونص ولا كيف؟ I don't know what does about 5 mean, you know. So actually in terms of dopamine receptor types, we have two families of receptors, what we call the D1 like and the D2 like. D1 like is D1 and D5, and D2 like is D2, 3 and 4. Okay. طيب شو اللي بيميز ال D1 like عن ال D2 like? Once dopamine binds to the D1 like اللي بصير عندنا excitation. Once the D2 like binds بصير عندنا inhibition. إذا زي ما انتم شايفين هون أنا حاطط D1 and D2 in terms of the basal ganglia أو عفوا الميديوم spiny neurons. إذا ديروا بالكم الدوبامين من وين بيجي كمان مرة؟ مش من الستريتم، بيجي من السبستانشيا نيجرا pars compacta أو من ventral tegmental area. Alright? Mainly from the substantia nigra pars compacta. Once it binds, وكيف اتفقنا it binds on the neck of the spine, not the head of the spine, the neck of the spine. بيعمل regulatory aspect of, you know, the cortical activation via glutamate. ولكن احنا dopamine comes and actually modulates this activity. Once dopamine binds to D1 بيعمل excitation. Once dopamine binds to D2 it actually inhibits the medium spiny neuron. إذا خلينا نفكر في هذا الموضوع كمان مرة. لما يجي عندي input من الكورتكس with D1 excitation مشت الأمور no problems. لما يجي عندي input من الكورتكس مع D2 بصير عندي inhibition not excitation. alright. إذا كمان مرة نفكر إذا صار عندي inhibition based on dopamine, okay, because it's D2, a D2 receptor, medium spiny neurons. إذا I lose this GABAergic input على ال globus pallidus external, and based on that, the globus pallidus becomes disinhibited. It releases more GABA على subthalamic nucleus, and therefore the subthalamic nucleus is much more suppressed, and this leads to disinhibition. Okay, loss of excitation. So basically leads to loss of excitation of the globus pallidus internal and the substantia nigra pars reticulata. إذا نخف الاوتبوت تبع البيزل جانجليا. So شايفين كيف الكورتيكال input لحاله كان balanced, بس الكورتيكال input مع الدوبامين started actually moving in a particular direction. So it's actually exciting the cortex. So the net result is dopamine with the cortical input or dopamine on its own is leading to a decrease in the output of the basal ganglia, which means we have more excitation, subsequent excitation of the thalamus and the cortex. أهم نقطة في المحاضرة هذه. Please make sure that you understand it. اللي مش فاهمها يحكي مشان نعيدها. بتمنى تكون واضحة للجميع. If it's not clear, please let me know and I'll be more than happy to repeat it. Okay, again, any questions so far? Okay, receptors كمان مرة. Receptors, we're talking about two families of receptors. وهنا for simplicity we'll be talking about D1 and D2. Okay, so D1 is excitatory. شو يعني excitatory؟ لما يربط عليه الدوبامين بيعمل excitation في السيل. و D2 is inhibitory. Okay. So I'll actually repeat both the direct and indirect pathway مع ال receptor subtype so that you see exactly what's going to happen. All right. Before I move forward خلينا نشوف هون dopamine excites both cortex and the thalamus depending on the type of receptor. إذا أنا بحكي على D1, yes, there will be excitation in the cell that actually receives dopamine. إذا كان عندي D2 like, it will be inhibited. See the point? So if the thalamus receives dopamine, and I'm not aware exactly which one, maybe it's actually CMT again, the midline thalamus actually receives dopaminergic input, but we'll need to check that. But basically in the cortex, إذا كان D1 like, then actually receive dopamine, yes, they'll be excited. The can D2, there will be inhibition. The same happens in other areas of the cortex and subcortical areas. كمان مرة, direct, indirect, in the striatum, and basically we want to try to understand إنه إذا أجى الcortical input هذا على D1 receptor on actually احنا بنيجي بنحكي على الكورتكس هنا D1 medium spiny neurons. يعني هذا الميديوم spiny neurons اللي جاي عليه الكورتيكال input عليه كمان D1 receptor. alright. إذا هدول السيلز specifically, these are the ones that project to the direct pathway. إذا أنا عندي two types of medium spiny neurons at the striatum, if this is not clear. واحدة عليها D1 واحدة عليها D2 mainly. okay. D1 medium spiny neurons and D2 medium spiny neurons. طبعا في sub category عليها اثنين D1 and D2 بس they're much less. Majorly D1, either D1 or D2. D1 goes actually basically to the direct pathway. D2 goes into the indirect pathway مثل اللي حكينا. الدايركت باثوي مثل ما اتفقنا من الستريتم للاوتبوت structures of the basal ganglia immediately. الدي 2 من الستريتم للجلوبوس pallidus external للسبثالاميك and then to the output structures of the basal ganglia. لما يجي الكورتيكال انبوت على دي 1 medium spiny neurons with dopamine, شو اللي بصير عندي؟ بصير عندي excitation لأنه دي 1 is excitatory والglutamatergic input من الكورتكس is also excitatory. فبالتالي بزيد الجابرجيك input على الاوتبوت structures of the basal ganglia, بنزل الاوتبوت تبع الاوتبوت structures of the basal ganglia, بنزل بخف الفايرنج تبعهم because we're inhibiting them. and then basically هذا الكلام بيعمل disinhibition للثالاموس which excites the cortex. كمان مرة بنخسر الGABAergic output. okay, basically loss of inhibition or disinhibition of the thalamus, therefore the glutamatergic activity of the thalamus increases. The indirect pathway, on the other hand, when we have glutamatergic input with dopaminergic input, so an inhibition, okay, mainly that we're talking about here, because again these are D2 receptors, and then this inhibition decreases the GABAergic output of these medium spiny neurons على external pallidus, external pallidum, external globus pallidus. And then basically this actually leads to disinhibition of the external globus pallidus, بزيد inhibition of the external globus pallidus على subthalamic nucleus. عشان هيك subthalamic nucleus بنزل الاوتبوت تبعها اللي هو ايش؟ glutamatergic. لما يخف عندنا glutamatergic excitation of the output nuclei of the basal ganglia، كمان مرة شو بصير في الاوتبوت تبع البيزل ganglia؟ بينزل. لما ينزل الاوتبوت تبع البيزل ganglia كمان مرة بنعمل disinhibition للثالاموس. So dopamine and cortical inputs accentuate movement. All right. So what drives the substantia nigra to activate D1 and D2 receptors? It's basically dopamine in general. عرفت كيف؟ And then هلا بنحكي كمان شوي انه basically how intricate this pathway is. راح افرجيكم كيف البارسلation تبع substantia nigra pars compacta. It's not a simple pathway. هتشوفوا كم how many inputs come directly to the substantia nigra pars compacta, and how does that actually project back to the striatum, وكيف topology of actually these different inputs and outputs من الcortex للsubstantia nigra pars compacta. So it's not a simple scheme of things. And then ultimately it's mainly it relates to the function. What really needs to be accomplished by these particular circuits. What other factors decide which receptors are more dominant? Again, basically what kind of cortical inputs, what kind of function that we're trying to support here. then زي ما انتم شايفين it's a balance between excitation inhibition بالdirect والindirect pathways. All right. So should I do like excessive movement initiation? Well, and actually that's what the basal ganglia is extremely important for. Movement initiation. All right. So think about it this way. And that's actually what you will see in Parkinson's disease. This is one of the major problems in patients with Parkinson's disease. يبلش يتحرك. Okay. And هذا هو اللي احنا بنسميه extrapyramidal motor input of the basal ganglia. طيب, okay, and I don't want to exhaust you guys nor myself. So basically let's take a 10-minute break, and then we'll be back to talk a little bit more about some of these models of basal ganglia, the center surround, as well as the what is it called, as well as the canonical model of the basal ganglia. And we'll talk also a little bit about eye movements if we find the time. But if not, then actually we'll مسامحكم فيها. As basically, it's also very important to know this. And then we'll talk about Parkinson's in particular, and then Huntington's, a little bit of coverage. And that should be it. المفروض انتوا هون يا جماعة for 2 hours. We'll try to finish as early as possible. Okay? Any questions? Okay, then happily. We'll see you guys in 10 minutes. Please be sharp at 3:01, 3:02, you know, 3:02, let's say, so that you take full 10 minutes to rest, and we'll resume in a bit. Okay guys, so اللي بيسأل عن الساعة يعني المفروض إنه يعني نخلص قبل الأربعة إن شاء الله. Hopefully as soon as possible. And yeah, إن شاء الله بتعبكم بشيء. So, all right, so there is a question. Direct pathway, goal is to create movement. Striatum inhibits, yes. GPI and pars reticulata stop inhibiting thalamus. In fact, thalamus is free to activate cortex, which is a D1 indirect pathway, is further inhibit movement if there is dopamine, of course, you know. Or actually no, it's accentuate movement if there is dopamine. يعني الدايركت والاندايركت باثواي بيشتغلوا بنفس الطريقة إذا كان الدوبامين موجود. إذا كان الدوبامين مش موجود, yes, they're opposing each other. بس إذا كان with dopamine, with D2 in particular, بصيروا بنفس الأسلوب. Both of them decrease the output of the basal ganglia. Alright? إذا كان الانبوت فقط من الكورتكس, الدايركت بيزيد الحركة or بيزيد الاكسايتيشن تبع الكورتكس, والاندايركت بقلل الاكسايتيشن تبع الكورتكس. Got it? اما اذا كان basically what is it called, اذا كان الدوبامين موجود والD1 والD2, اذا الD1 بيشتغل بنفس الاسلوب مع الدايركت باثوي, بينما الD2 بيعكس اللي بتشوفه في الاندايركت باثوي, بصير بنفس الاتجاه اللي بصير في الدايركت باثوي, which is decreasing the level of activity. Is all of this info in the files you send required for exam or just the topics you explain? غطينا هذا الكلام يا جماعة, حكينا عنه أول ما بلشنا المحاضرات. للي ما كانش موجود, اللي بده ينجح basically to pass, attend the lectures. You will have enough to pass and you'll have enough to even do well. اللي بده يجيب 100 بده يقرأ. It's very simple as that. Okay. So D2 overcomes the ultimate inhibition of the cortex. It's actually modulatory, so it modulates the activity in different ways. يعني just simplification. لما يكون في dopamine, okay? We assume that actually dopamine is gonna take charge here, and then ultimately that's what you will see in this particular neuron. Okay? So للتبسيط كمان مرة, it's not as simple as this, بس طبعا للتبسيط إذا كان الدوبامين موجود. هلا بنشوف لما الدوبامين ما يكونش موجود basically, and we'll see what happens. Any other questions? طبعا في concept في neuroscience بنسميه collaterals. Collaterals means or refers to neurons that actually send particular output of their axons, وبعدين بيعمل branching الأحسن, it goes somewhere else, or it goes and activates itself in a feedback loop, or self-excitation or self-inhibition. So you see this very frequently in these neurons, and ultimately makes the life of neuroscientists a lot more difficult. لأنه it's not يعني that's actually a very important concept in neuroscience. In the brain, very rarely you see something that we call serial processing. يعني serial processing. And A activates B, and then B activates C, and then C activates D. Okay, very rarely you see this. لأنه A it activates A مع B مع C مثلا, وبعدين it gives a feedback loop to itself. بعدين B بيجي بيعمل back propagation ل A, or actually back back projection ل A, and actually modulates its activity. وبعدين it projects to C and then projects to D. So it's a very complex system. So it's sometimes it's a logical error to try to simplify a complex problem. So let's just simplify it for the sake of trying to understand the basic architecture. But is it that simple? The answer is absolutely not. Is the brain a computer? It's not. Okay, so it's much more complex. Actually, you'll be surprised to know that in order to model one neuron, you will need a quantum computer, one neuron, with all of its complexities, and all of the things that are related to its axons and dendrites and so on and so forth, and the computational capabilities of a neuron. طيب, okay, beyond this kind of spiel of complexity and difficulty, let's talk about what we know. So as I mentioned, there is one of the corticostriatal loops is important for regulation of what we call saccadic eye movement. شو يعني saccade؟ saccade هو عبارة عن الحركة اللحظية اللي بتصير في العين actually, okay, horizontal mostly or vertical, and basically that is related to the exploration of the environment. بالعادة, what actually happens is that there are neurons. Actually, these are controlled by, of course, the ocular muscles. And there are neurons in the superior colliculus that are actually responsible for the control of these movements by the ocular muscles. And these neurons in the superior colliculus are the ones that actually they're usually inhibited by GABAergic inputs in the or coming from the substantia nigra pars reticulata in particular. فإذا لما يصير عندي أنا any kind of input, cortical input, what we call the supplementary eye field or the frontal eye field, to the striatum, and in that particular area it projects directly from the direct pathway onto the substantia nigra pars reticulata. Then actually what you see is, again, because these are GABAergic neurons, they will inhibit the substantia nigra pars reticulata neurons, and therefore once the activity goes down in the substantia nigra pars reticulata, the inhibition of the substantia nigra pars reticulata on the superior colliculus is lost, and therefore this increases the frequency of what we call saccadic eye movements. You start searching in the environment. And طبعا هذا بده يجي من cortical input, so that the facilitation of the eye movement happens. مشان هيك مسميها oculomotor corticostriatal loop اللي حكينا عنها في بداية المحاضرة. All right? As simple as that. Okay. There is actually another model that I want you to consider. It's called the center surround model of the basal ganglia. ممكن حد يجي يسأل, طيب بلزمنا دائما الدوبامين مشان نعمل حركة احنا basically. طب how does, if the dopamine is not necessary for the function that we're talking about, how does that happen? كيف البالانس بصير بين الدايركت والindirect pathway? One of the proposals, and actually it's based on anatomical observations, is called center surround, or the center surround organization of the basal ganglia. إنه كل batch of cells of the direct pathway, okay, D1 cells, like a cylinder, all right, is surrounded by another hollow cylinder of indirect pathway cells. So when you get excitation, okay, when you get excitation from the cortex, you actually you excite the center, and basically the surround is also going to be inhibiting anything around it. So إذا أنا بدي أعمل حركة بناء على هذا الكلام, كيف بعمل functional specialization? I select the batch of cells I want to activate via the direct pathway, and everything around it that actually is receiving the output in the indirect pathway is going to be suppressed. طبعا, of course, dopamine out of the picture here. Okay? يعني بحكي أنا بس على الcortical input هنا. So this is a simplistic way of actually thinking about this, how this happens. There are things that actually suggest that it might not hold for a lot of functions, but maybe for motor function, it makes sense. طيب, okay. Let's talk a little bit about movement disorders. And there is a lot of discussion of movement disorders in the field of, there's actually a subspecialty of neurology that is called movement disorders. بتركز على هاي الحركات اللي بتصير اللي بتشوفوها basically in relation to these disorders that potentially and mainly affect the basal ganglia. مين بده يحكي لي شو السيمبتومز اللي بنطلع عليها when we talk about movement disorders? محمد علي Clay, what did you notice إذا شفتوا فيديو له at some point? What do you notice about his hands? There are tremors, exactly. What else? Tremors, ممتاز. هذا بحكي لي على muscle tone. So في resting tremor, we call the resting tremor or the pill rolling tremor. ممتاز, which is a Parkinsonian tremor. Gait, exactly. شوفوا what's the problem with the gait? Ataxia, yes, but it's not basal ganglia in particular. Okay? Bradykinesia, slowness of movement. شو كمان? Rigidity. So you just named the triad of Parkinson's disease. Bradykinesia, rigidity, and tremor, basically. If you see these three symptoms, then what you're talking about is a dopamine affecting disorder that we call Parkinson's disease. طبعا حاليا ضافوا عليه في American Academy of Neurology. You need to look at something else that is called postural instability. Okay, so there are now four pillars for diagnostics of Parkinson's. Mask face, exactly another symptom of Parkinson's disease. طيب خلينا نشوف basically let's see, and هاي اللي راح افرجيكم اياها حاليا is basically available in the additional readings. It's actually called POW et al. 2017 in I think Nature Reviews. So let's see actually what these guys say here about Parkinson's disease and Parkinson's disease symptoms. So again, I want you to see that the motor aspect is very important for us to see what's happening, but it's not just the motor aspect of things, okay? So be aware of that. طيب ممتاز. إذا شوف كيف هون عندي أنا diagnosis of Parkinson's disease. This is actually where the patient is seen by the neurologist, and they say, okay, this person has Parkinson's disease based on the triad or a quadrad, basically, of whatever you want to call it, of Parkinson's symptoms. ولكن before that, do we see شيء بنسميه prodromal or prodromal Parkinson's symptoms? The answer is yes. As you can see, it's not one type of symptoms. There are multiple types of symptoms that actually could present themselves before you see things related or what we call the motor presentation of Parkinson's disease. حكينا عن بعضهم امبارح إذا تتذكروا. REM behavior disorder, restless leg syndrome, also mental health related issues such as anxiety and depression, hyposmia, loss of smell. This is actually one of the symptoms that you see of Parkinson's disease, excessive daytime sleepiness as well. So تذكروا امبارح كنا نحكي كيف these things are precursors to the manifestation of Parkinson's disease. Constipation, GI symptoms are also related to Parkinson's disease, early prodromal symptoms. And then you see the kick in of the motor symptoms. الموتور symptoms ببلشوا على جهة من الجسم يا اليمين يا الشمال, predominantly على الجهة اليمين من الجسم, which means the left basal ganglia, okay, لأنه contralateral, all right, activation of this. And then we're talking about tremor, bradykinesia, and rigidity. Almost 70% of patients come with presentation with a tremor, but these are not the dopamine-related symptoms. The dopamine-related symptoms are the bradykinesia and the rigidity, okay? So إذا بدي أسألكم predominantly what is the most important symptom that is related to dopamine dysfunction in Parkinson's disease, do not answer tremor. Tremor is not necessarily related to dopamine dysfunction. It's related to another basal ganglia, thalamic set of nuclei that could be actually treated. Okay, bradykinesia, exactly. Bradykinesia in particular is the most important, the slowness of movement. Okay, it's the most important symptom that is related to loss of dopamine. And as you can see basically here, الموضوع it actually evolves للأسف. Evolves in a negative way, of course. لأنه ليش مسمين neurodegenerative disorders؟ لأنه they degenerate. So it starts in one on unilaterally, it becomes bilateral, and then actually it starts progressing to include many more and many other systems, not just dopamine, but also it comes with different, unfortunately, flavors of symptoms, such as cognitive impairments, amnesia-related things, basically psychotic presentations. And once you introduce the medications, it becomes even more complicated. للأسف مع what we call dyskinesias, orthostatic hypotension, other symptoms, and then ultimately it gets to the point where we call it late stage Parkinson's disease, when it becomes, people, are unable to help themselves. they're unable to take care of themselves. حتى بعضهم they stop being even being ambulatory, and therefore you see much more frequent falls. They fall and they break bones unfortunately, and then this is how it happens. طبعا كيف بنحدد السيفيريتي تبعت السيمتومز هذه؟ طبعا في فرق بين ال presence of the symptom and the stage of Parkinson's disease, okay, and the grade of Parkinson's disease, or the grade of the symptom. So severity of the symptom and stage of Parkinson's, okay. So staging of Parkinson's is a classification system. One of the most commonly used ones is called Han and Yar, if you're interested, of course. And in order to classify the severity of the symptoms, we use something called the Unified Parkinson's Disease Rating Scale, UPDRS. Okay, if you're interested in the actual quantification of how things happen. طيب, let's go back to the chapter and see exactly what happens, from a gross anatomy aspect of things. As you can see here, this is a substantia nigra pars compacta, with the basically melanin pigment. And as you can see here, it's completely lost in a Parkinson's patient. There are no more dopaminergic cells. Dopamine cells, for some reason, die. But if I lose dopamine, what happens in Parkinson's disease? Let's follow the pathway. So basically, مين بده يتبرع يحكي لنا basically شو اللي بصير في الدايركت والindirect pathways? Who wants to volunteer? اللي جاوبني مثلا bradykinesia is actually the most important symptom of Parkinson's that is related to dopamine. Can you show us on the pathway why this happens? And again, just follow what I said and remove dopamine. Any ideas? Okay, let me take care of you guys. Loss of the direct pathway excitation and loss of the indirect disinhibition. Let's see if this holds actually. Let's see if this holds. And then ultimately we'll think about it together. إذا لما نخسر الدوبامين in this kind of context, let's just zoom in here. When I lose dopamine, مثل ما اتفقنا راح يكون عندي input من الكورتكس المفروض ما يتأثرش يعني. ولكن what happens with dopamine, it modulates the activity. إذا كان في عندي excitation بيزيد الاكسيتيشن. كان في عندي inhibition, it actually takes care of that. Alright? إذا الدوبامين شو بيعمل؟ It actually modulates the function. فبالتالي إذا if I lose dopamine على excitatory بروح الاكسيتيشن, بخف الاكسيتيشن. اوكي؟ على الدي 1 بخف الاكسيتيشن. لما يخف الاكسيتيشن بخف الريليس تبع الجابا على ال output nuclei of the basal ganglia, they become more active. وهذا الكلام بيعمل inhibition على الثالاموس, and therefore it inhibits the cortex because the thalamus is more inhibited. طب هذا اللي بصير على ال direct pathway when you lose dopamine. When you lose dopamine على ال indirect pathway, what happens? We don't have inhibition anymore. لأنه الانبوت اللي جاي is also is just excitatory من الكورتكس. I lose the inhibitory modulation of what happens there, and therefore we basically it's more of release of GABA على الglobus pallidus external, which means that it's inhibited, which means that the subthalamic nucleus is much more active, which means that the output nuclei of the basal ganglia are much more active because they get glutamate from the subthalamic nucleus. إذن كمان مرة شو اللي بصير؟ Inhibition of movement, inhibition of the thalamus, inhibition of the cortex. احنا بنحكي كمان مرة على الموتور corticostriatal loop. طبعا it actually generalizes as well to the other loops. بس طبعا احنا we're talking about functional loops here, all right? So that's actually what's really important. إذن loss of dopamine means what? Means decreased motor activity. Decreased motor activity. And this is exactly what we see with bradykinesia. And ultimately rigidity لأنه في عندنا decrease of muscle tone. Muscle tone بيلزمه السيجنال اللي جاي من central nervous system in order to function. If this is actually going to be diminished because of the inhibition that is happening because of the loss of excitation over actually often increased inhibition of the thalamus on the motor cortex, then you will see bradykinesia because there is no movement, there is no initiation of movement, and you'll see the decreased muscle tone, which would lead to what we call rigidity. And this kind of misbalance that happens in these thalamic, basically basal ganglia thalamic circuits that ultimately leads to what we call tremor, basically. واضحة؟ Is it clear? I hope so. اللي مش واضح رجاء اسألوا يا جماعة. I'm here to answer your questions. And it's a very simple concept. كمان مرة مثل ما شرحنا ال pathway that actually relates to the circuit. You just need to apply loss of dopamine there. مثل ما اتفقنا dopamine is important modulatory على excitatory على inhibitory. If we lose it, we basically lose both. All right? We lose mainly the excitatory. في شوية excitation, but it's not as much. Well, inhibition is actually mostly lost. Okay? And therefore, what happens is when you lose excitation, you lose GABA on the direct side of things. When you lose inhibition, you actually increase GABA on the indirect side of things. والنتيجة واحدة, which is increase in the output of the basal ganglia, which is going to suppress the cortex, the motor cortex. طيب هذا بنسميه احنا hypokinetic disorders of the basal ganglia. Hypokinetic فيها نقص في الحركة. طيب في another type of disorders اللي واحد منهم بنسميه Huntington's disease. في الهانتنجتونز ديزيز احنا بنسميه hyperkinetic. شو الفرق؟ مين بده يحكي لي شو الفرق بين الهانتنجتونز والباركنسونز من ناحية what's lost? Who wants to say to actually contribute here? عرفنا في الباركنسونز we lose dopamine by losing substantia nigra pars compacta, I'm sorry, and by losing frontal tegmental area as well, dopamine cells. So what happens in Huntington's? What do we lose? So one of the answers is that we lose GABA in Huntington's. What do you mean by GABA? What do we call them, the GABA neurons in the striatum? كمان مرة تحفظوش يا جماعة، الموضوع مش حفظ إنه أنا I lose GABA therefore it leads to excessive unwanted movements. How? That's actually the beauty of physiology. You need to understand how and why does that happen. So why does that happen? Okay? That's actually what you need to understand here. When I lose the medium spiny neurons شو اللي بصير في الهانتنجتونز؟ الميديوم spiny neurons die باختصار. في الباركنسونز dopaminergic cells die. In Huntington's, medium spiny neurons die. Okay? So the medium spiny neurons in the striatum die. So كمان مرة نشوف شو بصير if these cells die. If these cells die, then actually what we will see in terms of the globus pallidus internal, I'm often D2 in particular. Let me just modify this. The D2 neurons in the striatum, not all of them, not all of the medium spiny neurons. My apologies. Okay, so the D2 neurons are the ones that die. Okay, mainly especially in the beginning. All right, and therefore, and عندي excessive excitation. dopamine موجود, الcortical input موجود. إذا بناء على هذا الكلام بزيد عندي excitation of the D1 cells, the D1 medium spiny neurons. وبناء على excitation of these D1 medium spiny neurons, we have an increase or often a decrease in the activity of the globus pallidus internal, therefore a decrease in the output of the basal ganglia. مشان هيك more excitation of the thalamus and the cortex. بينما على D2 we lost the D2 ones. So what happens here? If I lost the D2 input على globus pallidus external, then the globus pallidus external is going to suppress the subthalamic nucleus because it's not inhibited anymore. And basically, the subthalamic nucleus is not going to release any more glutamate على globus pallidus internal or the substantia nigra pars reticulata. Then loss of excitation, which means basically less activity. So both directions mean that we will have a decreased output of the basal ganglia, therefore more facilitation of movement, and more excitation of the thalamus, more excitation of the motor cortex. واضح؟ Okay. Is that clear, جماعة? I hope so. So, of course, let me repeat this again. I know it's just it's a little bit complex. كمان مرة نشوف شو المشكلة في الباركنسونز قلنا loss of dopamine cells. شو المشكلة في الهانتنجتونز loss of D2 medium spiny neurons in the striatum. كمان مرة dopamine in Parkinson's, dopamine cells in Parkinson's, D2 medium spiny neurons in Huntington's. When we talk about Parkinson's, if we lose dopamine, we lose excitation on the direct and we lose inhibition on the indirect. If we lose excitation on the direct, معناته output of the basal ganglia will increase, which means inhibition of the motor cortex. When we lose inhibition on the indirect, this means that actually what happens is that there will be, again, more activity of the output nuclei of the basal ganglia. بس دايما اتبعوا pathway step by step so that you understand how it goes. And then ultimately, again, less activity in the thalamus, less activity in the motor cortex. Dopamine losing, dopamine leads to loss of movement in Parkinson's disease. في Huntington's, we mainly lose D2 neurons in the striatum. That's طبعا ultimately it becomes much more prevalent, much more universal and global, and therefore you lose everything. But initially you lose D2. عشان هيك you get this kind of abnormal, unwanted, unwanted movements that actually prevail in Huntington's disease. They call it chorea or Huntington's chorea. And then basically what you see is that there is still excitation with the D1 medium spiny neurons. This leads to a lower activity of the output nuclei of the basal ganglia. We lose D2 neurons, therefore this means that there's also less activity on the output nuclei of the basal ganglia. كيف? D2 are lost, GPE is more active, STN is less active, less glutamate in the output nuclei. Indirect will indirect, push toward more movement, more activity of the thalamus. ليش؟ لأنه lowering, both of them are lowering the output of the output structures of the basal ganglia. Less GABA in the thalamus, which means more activity in the motor cortex. But this is what you see in terms of unwanted movements in Huntington's disease. All right? Excessive movement as opposed to less movement in Parkinson's. بتمنى يكون واضح. If not, you can ask specific questions here, guys. And then let me show you. I don't know, do I have? Yeah, look at Huntington's disease. You see what the problem is? The problem is we're losing. So you can see here, basically, here is the caudate, here's the putamen, and look at the Huntington's patient. You see? Completely lost. This is basically what you see in the striatum. Okay, so the size of the caudate and the putamen is way smaller in this kind of regard. تمام? Okay, so let's see again. What do we have here? Okay, so this is basically what you see in terms of application of dopamine agonists. طيب, how do we treat Parkinson's disease? نرجع شوي نحكي على Parkinson's before we we will not talk about Huntington's in terms of treatment. We'll talk more mainly about Parkinson's. Then you need to know basically a little bit about not just the pharmacology but also the the way that the way to think about the pharmacology using the circuit. People are saying L-dopa, others are saying dopamine agonists, and others are saying anticholinergics. What else? طيب, let's think about it in a more categorical manner. Bromocriptine, which is what? Bromocriptine, مين بده يحكي لي؟ What kind of medication? It's a dopamine agonist, exactly. So that's basically what you want to think about. انه في عندي multiple strategies when it comes to treating Parkinson's disease. طب كيف بنفكر في هذول strategies? Let me see. I think I have another paper here to show you guys. I need a paper that shows the synapse and I can't recall if I put one or not. If not, I'll supplement one. طب بس خلينا نفكر في الساينابس يا جماعة احنا هنا. Okay? And then ultimately as you can see في عندي أنا let me use this as an example بس يعني okay, let me use this as an example. زي ما انتم شايفين هنا this is actually, let's assume that this is a dopaminergic cell synapsing on a medium spiny neuron. Okay, that's how we want to think about it. في عندي multiple components here. في عندي vesicles that are releasing the neurotransmitter dopamine. في عندي receptors على postsynaptic neuron. في عندي basically enzymes, and في عندي other types of transporters. إذا كمان مرة شو في عندي أنا هون؟ في عندي release mechanisms for the neurotransmitter dopamine. The dopamine binds on post synaptic receptors. It's being broken by enzymes in the synapse or being reuptaken by transporters. If I want to increase dopamine, what do? I either increase release by increasing manufacturing. This is what L-DOPA does. Okay. And or I just, I don't need dopamine anymore. بجيب الagonist or the antagonist basically here. We're talking about the agonist and we want to accentuate activity of dopamine. So dopamine agonists, and dopamine agonists basically depends on what type of receptor are we talking about. And what I do is I bind on the postsynaptic receptor directly بدون ما اني انا ازيد ولا اقلل ولا اتدخل في تصنيع الدوبامين in the cells. Or I inhibit the breakdown of dopamine by some of these enzymes, such as COMT, C-O-M-T, the COMT enzyme, the monoamine oxidase. So COMT inhibitors, MAO inhibitors are actually treatments for Parkinson's disease. Or I block the reuptake. I block the dopamine transporter اللي هو بيعمل reuptake. Okay, so these are the different strategies that you can use in order to treat Parkinson's disease pharmacologically. And I think this is a good depiction of that here, in terms of the dopamine medications. So let me show you. So and we'll talk in more detail about things. So let's look at dopamine in particular. So as you can see, dopamine receptor agonists. We have also, let me see, is levodopa here? It's not here. I can't see it. But levodopa is the gold standard for treatment. When you give the precursor of dopamine in the form of levodopa with carbidopa. طبعا ليش بنعطيهم carbidopa مع levodopa؟ مين بيعرف؟ Who wants to tell me why we give carbidopa مع levodopa? Without searching, it's just logic. It's تسألوش ChatGPT يا جماعة. Try to think. الدوبامين، كم نسبة وجود الدوبامين في الدماغ مقارنة في البريفرال system? How much of dopamine do we have in the brain as opposed to the rest of the body? Is dopamine important in the periphery? Does it have any functions in the periphery? أخذتوا cardiac system? So it inhibits the peripheral dopa decarboxylase صحيح. بس ليش؟ كم نسبة الدوبامين in the peripheral body as opposed to the brain? Any ideas? It's actually 85% to 90% of the body dopamine is present in the periphery. In particular, in the cardiovascular system, in the liver, in the intestines, and only 10 to 15% is present in the brain. That's it. So most of your dopamine, most of your serotonin as well, is located outside of your brain, not inside of your brain. Okay? So the amount of dopamine that we produce inside the brain is very minute in comparison to the rest of the body. عشان هيك في عندنا particular enzymatic machinery in the plasma, which is the dopa decarboxylase, that actually breaks dopamine or breaks levodopa whenever it sees it. Therefore, you need to inhibit this peripherally so that the drug gets to the central component and exerts its effect. Okay, so that's the idea behind it. After tremendous clinical trials and multiple development efforts, it seems that even though people were very excited about dopamine agonists in the beginning, apparently the gold standard still up until this day is levodopa carbidopa for treatment of the dopamine shortage that happens in Parkinson's disease. MAO inhibitors, COMT inhibitors are still also other options, but they're not as efficient as active. Okay, and therefore it's something to consider. One question: why is vitamin B6 avoided with these drugs? مين بده يحكي لنا؟ طيب اللي سأل السؤال will actually need to bring this answer next time. You need to do a little bit of research and tell us exactly why vitamin B6 is avoided. إلا إذا حدا عنده جواب طبعا. المشكلة anonymous attendee. I can't hold you responsible next time. Otherwise, I'll remember your name and then tell you to come with the answer. But maybe you can tell us next time. Okay. Okay, so then we covered basically the dopamine related physiology of how do we treat Parkinson's disease. And then ultimately I want you to also see this kind of sketch here of how prevalent these different types of dopamine receptors are, not in the basal ganglia only, but all over the brain. So basically we're talking about the cortex, we're talking about the hippocampus, we're talking about the different aspects of the thalamus and the hypothalamus. It's all over the brain. And actually, I don't know if you ever saw a picture of a dopamine neuron. I'll see if I can locate one before the end of the lecture. But basically, it's just, it goes from for example, we talked about the ventral tegmental area. It just extends the whole way from the midbrain all the way to the cortex. Same neuron. Okay? So basically, that's actually really something to fascinating about the dopamine neurons and how actually that works. A question: does marijuana relieve Parkinson's symptoms? And could you explain? The answer is partially is yes. Then it leads to more release of dopamine. Okay, but is it actually used for treatment? Not officially. Okay. Does it help? Maybe. Could. There is so much variability in terms of the response to marijuana, but it's not one of the typical treatments for Parkinson's disease. Inhalation marijuana actually helps in this kind of regard because it does accentuate the release of dopamine by blocking what we call the dopamine receptor, dopamine transporter. I'm sorry. Okay, and then therefore it's one of these things that are considered to help, but not necessarily help. Another question: why does acetylcholine increase in Parkinson's? Well, actually, it doesn't necessarily increase. It's actually like a postulation that it does increase. And the people propose that actually there is a balance between acetylcholine and dopamine in the striatum. And once you lose dopamine, so then acetylcholine is much more prominent, and therefore you knock it up by giving anticholinergic. And these drugs have been actually discontinued in the practice of neurology almost 20 years ago. Very rarely you see anybody using them these days in patients with Parkinson's. السبب إنه بيعملوا dementia. They cause a lot of memory problems in patients with Parkinson's. للأسف لحد الآن بنوصفوا عندنا في البلد في فلسطين I saw a lot of patients are actually on them. I published a few papers about this. You can look them up. But the fact that actually here أنا بقدر أحكي لك عن ال US in particular, nobody uses them, not anymore. Anticholinergics, okay? They help with the motor symptoms, but they cause significant cognitive decline, especially with memory. لأنه they affect the hippocampus in one way or the other. Okay, so it's not only dopamine. We're talking about, dopamine as an only resort for treatment. It isn't. There actually are many other neurotransmitter systems that could be targeted in Parkinson's disease. The serotonergic system is one of them, and I'll go through them so that you're just aware of them. I'm not going to focus specifically on the details or how this happens on all of these systems, but basically I want you to be aware that actually, you can treat Parkinson's disease with, let me show you the list of medications. And again, you can treat Parkinson's disease with serotonin receptors or receptor antagonists, okay, as you can see here. And then based on that, you that's a possibility for the treatment. So it's not just dopamine. الزميل أو الزميل اللي ذكروا الacetylcholine as well. Again, it helps a lot tremendously with motor symptoms, but it has significant detrimental cognitive effects or side effects. Norepinephrine is also used because you see adrenergic receptors in the striatum and in the substantia nigra as well, alpha and beta, mainly beta in the striatum 1 and 2. Glutamate. احنا المشكلة اللي عندنا أساسا هي في الجلوتامate والجابا. So why bother about dopamine in this kind of particular aspect? Why don't I modulate the GABA aspect of things? Increase inhibition في basically في indirect pathway and decrease inhibition في شو اسمه في direct pathway. Why shouldn't we do that? Or maybe just do glutamatergic activation to counter the inhibition that is happening. It's not that simple. ليش؟ لأنه ال pharmacological agents are universal. They will bind on everything. It's not that you select the circuit or the sub-circuit that you want to modulate or modify here. It goes everywhere, and that's a problem with it, okay? Dopamine is not more selective, no. You're increasing dopamine everywhere, all right? But specialization of the dopaminergic neurons, it's what makes it more efficient, okay? لأنه الGABA والglutamate are much more prevalent in the brain, all over the place. The dopamine, no, it's selective where it connects. Yes, you see it everywhere, but it's the neurons that actually carry that signal are not as prevalent as GABA and glutamate, okay? That's why you see the effect better. But are there no treatment strategies using GABA and glutamate? There are. Are they that efficient? There are some in the trials. But I didn't see anything that come out to market to actually show that actually it works. Acetylcholine, not just anticholinergics, but also basically acetylcholine mimetics, basically the things that excite the muscarinic receptors, and even some of the alpha receptors have been tried to treat Parkinson's disease. And so as you can see, there are multiple aspects, multiple systems that are used to treat Parkinson's disease, and ultimately it's not a one-size-fits-all, but you should be aware of that. Okay. Last thing I will talk about today is called deep brain stimulation. In the late 80s, early 90s, people said, well, we have this problem in this set of structures that is called the basal ganglia. If we stick an electrode in the patient's brain who has Parkinson's disease, can we help? Can we actually excite that area that is basically very inhibited in this kind of regard? And can we help by saying, I want to excite or inhibit these particular areas that are in the brain. زي ما انتم شفتوا يعني basically في عندي أنا مشكلة في direct pathway وفي indirect pathway. So maybe if I go to the globus pallidus internal and do something, or the substantia nigra pars reticulata and do something, or even the subthalamic nucleus and do something, then actually, surgically speaking, then I might be able to help the patient. ولكن again, the observation that was actually that preceded this was that you see very predominant beta oscillatory activity in patients with Parkinson's. As if the basal ganglia and the cortex are significantly synchronized. يعني كانوا بيشتغلوا بنفس على نفس الرhythm تماما. And when this happens, it's very unlikely that you will see actual motor initiation and actual movement when this happens. So basically, people started sticking these electrodes, experimenting with animals. In particular, one of the innovators in this kind of domain is called Malon DeLong, and in the early 90s. And طيب أنا لو بدي أرجع كمان مرة على البيزل جانجليا architecture هنا with Parkinson's disease. So DeLong stuck electrodes in the GPI and started injecting current. يعني in other words, you're activating the neurons. طب إذا أنا بعمل activation للGPI شو راح يصير as an output nucleus of the basal ganglia؟ المفروض تخف الحركة مظبوط لأنه I'm exciting it, I'm activating it. ولكن في الحقيقة it significantly reduces the symptoms of Parkinson's. طب شو اللي بصير؟ طب إذا حطيت الإلكترود in the subthalamic nucleus and I excited it، طب ما هو if I excite this it's gonna release glutamate in the GPI, and glutamate in the GPI means more GABA in the thalamus and less activity. طب what happens? How does deep brain stimulation help treat Parkinson's symptoms? So the little secret here was it doesn't really relate to whether you excite or inhibit. It's actually it's more related to breaking the synchrony. بما انه عندي predominant beta oscillation that happens with Parkinson's disease. When you do stimulation, you decrease the predominance of the beta oscillation. فبالتالي الcortex والbasal ganglia بيبطلوا in sync, بيبطلوا synchronized on this oscillation. فبالتالي this actually allows them to talk to each other in a way, which is quite fascinating. It's just it just shows you it's not serial زي ما حكينا في البداية. It's not A to B to C to D. It's much more interconnected. And to show you this actually in more anatomical terms, take a look at this figure. This is from basically Susan Haber and Brian Knudsen. It just shows you the what we call the parcellation of anatomical parcellation of let me see here. Try to stay on the same page while not, Okay. Maybe not this one. I apologize. 1 second. Oops. This one. Yeah, there we go. Okay, so what you see here is the interconnectedness between the substantia nigra, pars compacta and pars reticulata, by the way, and the striatum. And each one of these is color-coded by the cortical area that projects to the striatum. So you can see حتى في السبstantia nigra, pars compacta and pars reticulata, there is significant parcellation and functional specialization. And if I stick an electrode with أعطيه دواء that actually goes throughout the system, what happens to this? It's going to be flooded with dopamine. All of this, the whole thing, is going to be flooded with dopamine. But maybe it's not the effect that I want to have. So that's a challenge that we're facing. Although deep brain stimulation helps, طبعا في particular considerations to make when you are recommending a patient for this, especially that these patients should not have dementia. If they have dementia or other non-motor symptoms of Parkinson's disease, they're not good candidates. If they have bilateral symptoms and expression of non-motor symptoms, then actually they're less of good candidates for the treatment of deep brain stimulation. Remember this fact. Okay, Jamal, so this actually brings us to the end of today's lecture. I hope you learned something new. Any questions before we conclude this? Anybody who wants to ask using voice, please raise your hand and I'll happily unmute you, or you can just post it in the chat. Allah yafikum. Okay, so if there are no other questions, you should know about deep brain stimulation. Yes. جاي عليه سؤال في الامتحان وسؤالين, so اعرفوا. I know this is what you care about, guys. It's quite simple. The concept is quite simple, you know. So yeah, you should know about it. And I think يعني كمان مرة إذا بسمع المحاضرة, you will have all of the details that you need. All right? In order to do, you know, relatively well in basically the exam that we're talking about. I apologize. Okay. So that being said, it's the conclusion of the lecture. And we'll see you guys tomorrow, inshallah. And we'll be talking about associative learning, Pavlovian instrumental conditioning, and the brain circuits that would support this kind of function. Until then, if you have any other questions, save it for tomorrow and we'll dedicate time for that. يعطيكم العافية جميعا. السلام عليكم.